The most recent one was a patient who was otherwise healthy, lived in the Southeast Mid-Atlantic area, abnormal methylation signal detected. And, the DH&P, nothing there, nothing obvious on the labs, and went to imaging and had a low-grade B-cell lymphoma diagnosed early. And I think we all know that getting almost invariably early detection really changes this treatment and the outcome paradigm across cancer types. And this is one that was completely unsuspected. Patients feeling great, no signs, no symptoms, no class B, type B symptoms of night sweats and that stuff, but was able to get diagnosed earlier and is currently in treatment. And the idea is, wow, we had an impact. We changed the course by getting this patient diagnosed and detected earlier. And that's really exciting.
Welcome to Personalized by VitaminLab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Duizer. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome to Personalized by VitaminLab. I'm your host, Dr. David Duizer, and today I'm joined by someone who has spent decades on the front lines of cancer diagnosis, not at the bedside, but at the microscope. Dr. Richard Bernert is a board-certified pathologist with triple certification in anatomic pathology, clinical pathology, and dermatopathology. He trained under one of the most respected dermatopathologists in the world, completed a decade of service with the United States Air Force Medical Corps, founded Arizona Dermatopathology, and has spent 25 years leading diagnostic laboratories at the highest levels of both medicine and administration. But what makes today's conversation so compelling is what Dr. Bernert is building now. After a career spent witnessing what late-stage cancer diagnosis looks like, from the first tissue specimen to, in his words, post-mortem examination, he made a decision. If the system wouldn't catch cancer early, he would help build one that does. As Chief Operating Officer of Precision Epigenomics, he's working to make multi-cancer early detection affordable, scalable, and reliable. This is a conversation about what pathology teaches you that no other field can, why stage 1 detection is one of the most important frontiers in medicine today, and what it actually takes to transform that vision into something clinicians can use in their day-to-day practice. Please enjoy our conversation with Dr. Richard Bernert. Welcome back to Personalized. I'm your host, Dr. David Duizer, and I'm here with Dr. Richard Bernert. How you doing today, Richard?
I'm doing great, Dr. Duizer. How are you today?
I'm doing excellent. Yeah, thanks so much for coming on the show. I'm really excited to speak with you. I just recently met you, and it's been a pleasure, and I'm thrilled to know about you and your company. And I've been searching for someone like you and your company for years. And within a few days, you decided that you could make time for me to come on the show. So thanks so much.
Yeah, these things happen for a reason sometimes. It's a blessing to meet you and to be able to, get with your listeners and viewers and kind of just exchange ideas and tell you about what we're doing.
Awesome. Well, I'm glad that you're excited too. We have really two goals with the show. It's like, first is how do you personalize your career in medicine, lifestyle support, nutritional support, basically in integrative care. How do you get to a place where you feel like you're having the most impact? And you've been on a journey to get to this spot. Can you tell me a little bit about how you got to this place where you can have this kind of impact?
Yeah, so I'm an older guy. I'm 59 years old. I've been practicing medicine for quite a while. I got out of medical school in 1993 and did a residency in anatomic and clinical pathology. So laboratory medicine has already just been a very interesting place for me for many, many years. And I've had an extraordinarily successful and happy career. I did some active duty time in the military. We had wonderful times, served in the Air Force, met some of my best lifelong friends in the service, but then got out and worked for a large private group, super nice folks. But I decided that it was important to kind of find my own way and blaze my own way. So I started a practice of my own and basically it always committed myself to making the patient the purpose. So as long as we always took care of the patient, we knew we'd be successful and the business would follow. And it worked out very well. But, towards the end of it, I'm sitting there looking at it through a microscope, 8, 10 hours a day, weeks turn into months and years. And I was in a position, knowing what I was doing was incredibly important. Does this patient have a melanoma, or is it just a benign mole? Is this a squamous cell carcinoma or Paget's disease, for example? But at some point I said, right now I'm like the umpire behind home plate, just calling balls and strikes. And that's important. But I looked at a lot of my clinical colleagues who are out there that are, changing the course of patients' lives by encouraging them to behave differently, to do different things, lifestyle modifications. And I thought, how can I get onto the field and help a little bit more? So we started Precision Epigenomics, which is a clinical laboratory company based in Tucson, Arizona, about 4 or 5 years ago. And the idea was, how can we take what's a global catastrophe of delayed cancer detection and just have an impact? Maybe we don't save everyone, but if we can improve, that would really be just a tremendous way to have an impact and to help patients and help clinicians and help their families, less suffering. So that was really what got me to precision epigenomics. And it's been an extraordinary journey so far.
Tell me about the 4 to 5 years, like extraordinary journey. What is that? Like, how does this thing start? How does it evolve?
Yeah.
What have the last few years been like?
Well, it's really something you have to experience. There's some things that you can't describe in words.
Yeah.
And starting your own practice and developing a novel laboratory developed test that's never been done before is one of those things. So there's everything from the nuts and bolts of setting up a CLIA approved laboratory so that we can launch a laboratory developed test that can be offered to patients and clinicians, and that involves just so many things. It's just, fortunately I've done it before, so it wasn't my first time. And I was able to avoid a lot of mistakes. But doing the nuts and bolts, the blocking and tackling of setting up a clinical laboratory is one thing. Getting the best team to help has just been such a blessing too. And then finally, making sure the science supports the test. And, you can't wait 12 years to validate a test and validate outcomes before you get into the game. I mean, there's just too many people dying every year. There's 20 million new cancer diagnoses worldwide and 10 million people dying from cancer every year.
Wow.
And it's like, okay, are we going to wait another decade and tinkering, or are we going to validate a test, show that it works, continue to publish? And it's a lot like building an airplane that's already, taking off as you're going. So it's just so exciting. But having good team members has just made all the difference. And getting support from clinicians that say, yeah, we believe in what you're doing. And even the investors that we've had have said, yeah, this is important. I've been impacted by cancer. I need to make an impact. Here's some resources. And that would even include the NIH. We've been fortunate to get some grants to help support the mission as well. So,
wow, very cool. Well, I don't know the science here. I don't know the background and how this test kind of came to be. Like, so 4 to 5 years ago, whose idea was it? Where was the science? Like, how did you know this was going to be such a hit?
Yeah, so it's one of those things that, like a lot of things, there was an idea of circulating tumor DNA. And maybe if I can just spend 3 or 4 minutes just talking about what we're looking at and how it started. But so back in my day, if you told me that there was a possibility that somebody could actually, detect stage 1 cancer by looking in the blood, I said, well, that makes no sense. If it's stage 1, it hasn't spread, it hasn't metastasized, there's no way a blood test would pick it up. But we figured out over the years that there's something called circulating tumor DNA, or in general, cell-free DNA. So everybody listening to this podcast or viewing it has cell-free DNA in their body. So as the cells in our body grow, some are dying and they're senescent, and they undergo apoptosis or apoptosis, which is programmed cell death. And individual cells, whether it's in the liver or the colon, will start to die, and they release their cellular contents and their nuclear contents, or the DNA, the nucleic acids. So we all have that normal amount of cell-free circulating DNA in our body. But just like, 30 years ago with pregnancy, we had to put a needle into the womb and pull out, cells to see if it was a boy or a girl, for example. Now we're able to see tiny fragments of cell-free DNA from the fetus floating around in the mom. And we can do this non-invasive prenatal screening for all kinds of things. It's the same premise. Little bits of circulating tumor DNA from cells that had died that are floating around in the blood. And what we have found is that cancers, whether they're small or large, as they're growing, some of those cells are dying as well. And we know that cancer, 30 years ago, we thought the DNA sequence, is there a deletion? Is there a translocation? Everything was based on DNA. But we've also found that the epigenome, and I'll talk about that again a little bit more, is also important for cancer development. So those tiny little fragments of abnormal DNA in cancer floating around if you have cancer, and those are going to be found in the blood, just like fetal DNA would be found in blood in pregnancy. Let's pivot to the epigenome for just a minute, because
Please.
This is really something that I had no idea about for all of my medical education and training. And to be honest, even before I came to precision epigenomics and we developed EPISEEK, it was just a little bit of information in the back of my brain that I was familiar with, but it wasn't practical. So, there's only so much I can put in an old man's brain. And
Right.
I didn't spend a lot of time on it, but everyone knows that almost all the cells in our body have the same DNA sequence, right? So whether it's a skin cell, a brain cell, a gut cell, a liver cell, the same DNA is there. Well, why does the liver cell behave the way it does and a skin cell make keratin the way it does? And the way that's controlled is by the epigenome. So the epigenome says, okay, look, this is a skin cell, so we're going to wad up this DNA that makes mucus, for example, and stuff it in the corner of the nucleus, keep it inactive. And under the microscope, that's called heterochromatin, but it's the dark stuff that you see in the DNA. But other parts of the sequence that we need to be open so that it can be transcribed and translated into keratin proteins, that's that loose, clear stuff in the nucleus called euchromatin. And it's the epigenome that decides what's open and what's closed, and what's expressed and what's not expressed. And we know that methylation, or adding a CH3 group to parts of the DNA, will encourage the DNA to clump up and just go sit in the corner of the nucleus and be inactive. Well, we found out that with cancer, there are certain areas that are always hypermethylated. So they've always got too much methylation and they're turned off and wadded up in the corner of the cell. And that's a theme that we have found for cancers, whether it's brain cancer, liver cancer, lung cancer, testicular cancer. We've looked for common threads that are always abnormally hypermethylated in cancers. And then we've created a blood test using a patented probe set that looks for those specific areas that are hypermethylated. And if we see DNA that's hypermethylated in those specific areas, that's an abnormal methylation signature. And we tend to see that in folks that have cancers of various kinds. So it's really astounding. Wow. Because we looked through the Cancer Genome Atlas, which is like the Encyclopedia of Congress of cancers, and just found common thread. What's always abnormal in squamous cell carcinoma of the lung, and germ seminoma of the testicle, and low-grade glioma of the brain. We found that doing just very, very complex bioinformatics, created a probe set, and now we have the EPISEEK multi-cancer early detection blood test that's available. So wow. That was a lot. I feel like I need to pause. I'm sorry if that was a blitz.
No, don't be sorry at all. That's excellent. And in fact, for myself and for a lot of practitioners who are watching, having you review that is so helpful. Obviously, I've studied all of these things individually, right, but haven't put them together in a way that like I can just rattle off. Like, that's amazing. I just love that you did it exactly that way. Now, I'd love for you to do it one more way. For the people who are watching, who are talking to patients all day long, right? What is the version of this that would be sort of in English for a 14-year-old? Not necessarily like a 10-year-old or an 8-year-old, but maybe for a 14-year-old. How can we explain this in less than a minute to a 14-year-old?
Yeah, that's a great way to tee it up. And what, as a pathologist by nature, I'm a bit of a nerd and an introvert. So I'm glad we have confident clinicians that can do this at a high level. But yeah, we all need nerds. I mean, it's a great place to be. But the way I would explain it is, say, most people that are walking around don't have cancer, and they're not going to have these abnormal signatures in their DNA floating around in their blood. But many people that do have cancer will have these abnormal DNA fragments that are floating around in their blood, even if it's early, stages 1 or stage 2. And what we'd like to do is take a small amount of peripheral blood, so venipuncture, shouldn't have said venipuncture, just a small stick with slight discomfort, just to collect some blood, and we're going to look for these tiny little abnormal fragments that might be floating around in the blood if you were unfortunate enough to have cancer. So I guess that's probably the easiest way to do it.
VitaminLab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and VitaminLab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
That's really perfect. And that actually leads into some of the follow-up questions I have. Say you explain it like that, and someone says, well, do you always catch it? Are you going to be missing some? Like, how do you know you're getting it?
Yeah, that's a great question. And I want to be clear. In laboratory medicine, there are no perfect tests. And this is still early days, and it is an imperfect test. So I think the way to think about this is just to go through a little bit of biostats review. And most people have forgotten this since school and training, but it's always good to have a refresher. So we'll start with specificity. And the way to think about specificity is how good is the test at giving a normal result if the patient really is normal and doesn't have cancer. So if we said there are 1,000 folks and we know absolute ground truth, they do not have cancer and they don't have a precancerous condition like a intraductal papillary mucinous neoplasm in the pancreas or an advanced adenoma in the colon. So if we have 1,000 folks, how good is the test at saying it's a negative? And for the screening test, we generally want the specificity to be pretty high. So for our test, it's 995 folks out of 1,000 are going to get a normal result if there really is nothing there at all. So that's specificity. Sensitivity says, okay, if there are 1,000 people that we know have cancer, and we're just going to pick a gamish, we'll say everything from thyroid to lung to liver to pancreas to brain cancer, how effective is the test at detecting cancer? And we can look at it a number of different ways. When a patient has stage 4 cancer, there's tons of ctDNA or circulating tumor DNA in the blood, and the tests tend to perform better across different tests that are out there in the market. But that's not exactly early detection, right? Somebody has a big lump in their jaw and you say, hey, the blood test's positive. You haven't really helped that much. We tend to focus on how does the test do with stage 1 and stage 2, because that's where we can have the most impact. So for sensitivity for our particular test, the sensitivity for stage 1 and stage 2 is about 45%. And your listeners might say, 45%? Give me a break. Okay. But currently, screening for liver cancer is 0%, for brain cancer, 0%, esophageal, 0%, stomach, 0%. Wow. So 45 is pretty good. And you'll find it's actually 50% better than the 2 major competitors that are out there in the market who are in a similar space, but do a very different technology. A more expensive test, takes longer to get results, and it's just not as sensitive as what we're doing with our PCR platform. So overall, I'd say, we're going to be getting 450 out of those 1,000 across stage 1 and stage 2 cancers when there's a real chance for curative intent with surgery. And that's substantially better than what the other folks are doing out there.
Okay, so let's break this down for the clinician who's talking to the layman. We have a situation where someone runs EPISEEK and they get a negative test. They do not have cancer reported on that. Then we would say that with very, very high certainty, they don't have cancer.
Yes and no. So it is nuanced. So I'll say this. So we know that so first of all, in the general population, let's just say of adults 45 and older, let's just say 1 out of 100 is going to have cancer that we don't know about. And that's a fair estimate of what's going on. So we know that whether they take the test or not, there's a 98 to 99% chance they're going to not have cancer, right? So what we're doing is looking for very rare events. So we're going to be looking to say, we already know the pretest probability is quite low.
Yeah.
If somebody gets a cancer signal not detected result, then what we can tell them is there's a 99.5% chance they don't have cancer. It's not 100%.
Yeah.
It was very likely they didn't have cancer just on odds. With a negative EPISEEK result, it's even more likely they don't have cancer. And we've looked for all those other kinds of cancers that they're not able to screen for with their conventional standard of care screening, like colonoscopy or FIT test or mammogram and pap testing, things like that. So a negative result can be reassuring, but it should never be considered absolute. So for example, we would never encourage a patient to say, hey, I got a negative EPISEEK result, I'm going to skip my colonoscopy this year. And EPISEEK is always designed to be supplemental, in addition to, not instead of, standard of care screening. Now, that said, the best screening test is the one that gets done. So we know that some people just won't get a colonoscopy. They don't want to do the prep, or they don't want to go through the procedure. So for them, we say a FIT test is a good idea. And likewise, an EPISEEK multi-cancer early detection blood test might be a good alternative as well. But ultimately, we never want anybody to not take standard of care screening. Don't skip your mammograms. Don't skip your pap test. Don't skip your conventional screening. If you're a smoker, make sure you still get your low-dose spiral CT, those kinds of things. So that's the nuance, is that we always want people to understand it's great that it's negative. It can be reassuring that it's negative, but it can't replace standard of care screening.
That's really important for you to say, and for clinicians to remember. We can also say 99.5% chance you don't have cancer. And if you were a healthy individual going for prevention anyways with no symptoms, it was probably, greater than 90% you didn't have it anyways, but now we know it's 99.5% and still follow standard of care screening. Is that fair to frame it like that?
Absolutely. That's a great way to say it. And the way I always try to communicate it too is that everybody knows that screening for colonoscopy, colon cancer, for something is essential, but this is a chance to look for all the other cancers that are much more likely to get. So, for somebody my age, colon cancer, if I'm unfortunate enough to get cancer, there's only an 8% chance that it's going to be colon cancer. It's more likely to be something different, like lung, liver, pancreas, esophagus. This is a chance to look for all those other things. And it really should be part of anyone's long-term longevity, integrative wellness journey. Is nothing can blow up a longevity and a health plan like a late-stage cancer diagnosis. So it's really needs to be part of that conversation.
Completely. Let's go with the other example now. You can tell that this show is a lot about communication, because that's what we do all day around here.
It's essential.
It is. So now let's say EPISEEK is run, healthy individual, comes back positive. Talk to me about how to explain specificity to a layman.
Yeah.
In that situation. So, it came back positive. Oh no. Oh my gosh. What the heck?
Yeah, exactly.
Okay, so how do I explain this to a layman?
Yeah. So let's start. I'm going to circle to it, but first I want to set the table with mammography. And I alluded to it slightly earlier, but let's do it now. So we know that lots of women are getting mammography. We know that there are lots of abnormal mammogram results that require an additional next step. So mammography is screening. We see something that's unusual, and we decide, okay, we need to do a diagnostic maneuver. Maybe it's a fine needle aspiration. Maybe it's a true cut biopsy. Maybe it's an open biopsy. We know that the positive predictive value for mammogram, in other words, abnormal mammogram, how likely is it that there's actually going to be breast cancer? It's about 5%. So the positive predictive value of mammography is about 5%. And we're okay with that with screening. We're willing to have false positives so that we can cast a broad net, capture anything that's suspicious, knowing that 95 out of 100 are going to be normal or not cancer. I mean, normal is a strong word, but not cancer. 5% will end up having cancer. So that's the positive predictive value. How likely are we going to see cancer if the screening test is abnormal? Okay, so let's get to EPISEEK. And EPISEEK has a positive predictive value of about 64%.
Okay.
So 5% versus 64%. So there will be false positives, as with every screening test, but it's relatively low. An easy way to just kind of paraphrase it is, and it sells us short a little bit, that said, a negative means it's very, 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 very unlikely you have it. A positive, it's still about a 50-50 chance that there's something here, it's normal. So we don't want anybody to panic and get too excited. But what we have found is that if there's an abnormal EPISEEK result, we say, all this means is that you're somebody who we want to spend a little bit more time with. And we actually don't say cancer signal detected.
Right.
We say abnormal methylation signal detected. And one of us, either Dr. Ruth or I or another pathologist, will call the clinician and say, hey, we've got an abnormal, let's talk through it. What we found is sometimes people are doing off-label use, and we found out, the patient actually has a breast mass but was refusing a biopsy. So I said, if it's positive, they would do the test. Not how we've designed the test, not the way the algorithm's constructed. But in other cases, there's no history. The patient's completely well. So when that happens, what we'll usually do is talk with the clinician and say, these are the reasonable next steps. So the first thing would be a very thorough H&P. History and physical is always the cornerstone of what to do next. Is there really lymphadenopathy? Can you feel a spleen or a liver? The next thing is, are they up to date on their standard of care screening? Is this a 64-year-old woman who's never had a mammogram in her life? Okay, well, let's get up to date on those kinds of things, because common things are common. Then we would look at some proteins, and proteins have been around for decades. So we know that if somebody has a cancer signal detected and say they're my age, it would not be unreasonable to start with a PSA to look at things like that. For women, you might do other proteins like a CA19-9 or things that might look for ovarian. But ultimately, almost invariably, we end up going to some kind of whole body imaging. So it might be whole body MRI. It might be a PET CT scan. Both of those have been shown to be very effective for finding meaningful sized tumors. I guess the problem with some of those imaging studies is that they won't detect the smallest of lesions, but we're generally okay at missing that. For example, I mentioned earlier there's some precancerous lesions, or what they call high-risk lesions in the pancreas, called intraductal papillary mucinous neoplasm. And those are small little cystic things, and lots of people have them. I actually have a couple.
No way.
And as a rule, they're something to be aware of, but they're not something that people need to panic over. We know that EPISEEK will detect those small precancerous lesions. So an abnormal EPISEEK could be due to a precancerous lesion, or a high-risk lesion, or a carcinoma in situ, things like that. But generally, it's going to be imaging, and then if we don't see anything, we're going to stop. We don't want an abnormal EPISEEK to become somebody's core personality trait, and they perseverate and focus on it. So that's going to be part of that conversation on the front end, is if it's abnormal, we're going to do some imaging. We're going to do a little bit more blood work, including, I didn't mention a CBC, but looking for leukemias and myelomas, for example, lymphomas. And then we're going to stop if we don't see anything, and we're going to consider it a false positive.
Right.
And it is true that some of those false positives are going to be false positives. In other words, the patient does actually have a very, very tiny cancerous or precancerous lesion, but that's not worth chasing down. And the body can sometimes take care of those things on its own.
Good point. The structure that you've gone there, the step-by-step process, so helpful. And the fact that you give clinical consults makes a huge difference. I work with a lot of labs that do offer that, and I take advantage.
Of course,
I honestly think that people should, especially if you're new to a test like this.
Absolutely.
So I'm so glad that you're doing that. That's really helpful. Not that I won't go back and watch this and take notes again, but it's so valuable. Now, what happens in my office, and I'm sure a lot of the naturopathic physicians in British Columbia watching, is people come in and say, I just need you to do CA125, CA199, CA153, CEA. I want a PSA and a colonoscopy. I want to have all of that. Now, they have nothing happening. They have no symptoms. They have no other labs out of range. And I'm thinking, let's do EPISEEK instead.
Yeah.
I can go into sensitivity and specificity pretty well because I teach lab diagnostics, and so I know a lot about tumor markers. But I'd love to hear your pitch for that person. What would your pitch be if you were to meet them?
Yeah, yeah. And so I want to show courtesy and respect to the protein antigens that have been around for
They don't need
decades.
it. They don't need it.
But I mean, in fairness, they've been around for a while, but we know that the sensitivity and specificity is just not there.
Right.
So it's all we had for a while. It's kind of like, a PAN lateral X-ray were way better for a long time until we got CT imaging, right? So
Right.
it's kind of the same way. It's a paradigm shift. So there's a time and a place for proteins. They're incredibly affordable, but they're not, it's a little bit like using a blunt tool for surgery. It's just not where we need to be at this point of the game.
Yeah.
So ctDNA is one of the new molecular markers that's available, and methylation specifically is, I think, where we're going to be for a while. There are going to be some other things as well. So sequencing is going to be a piece of it, but we have to find that balance between what's reasonable and affordable and practical and globally scalable for this problem and what's effective. So a $4,000 screening test is not going to fly in any country, even the wealthiest countries. It just makes no sense. But a $20 test that gives so many false positives that people are going to end up getting all kinds of workups also doesn't make sense.
Right.
So I think right where we are right now is the sweet spot. So our goal is to make the EPISEEK test a globally scalable, globally accessible, meaning price-wise, solution that people can afford, have the test run locally in their communities. That'll help keep the costs down. Currently, we're shipping specimens from all the provinces down to the laboratory in Tucson. And, FedEx takes a big chunk.
Yeah, they do.
They take their chunk, and it costs money. And if we can get away from that and get away from customs having to inspect slow things down, I think it's going to be just a much better end state. And that's our goal. But yeah, proteins can be helpful in very specific situations. Even PSA as a screening test for men, the USPSTF has gone back and forth 2 or 3 times already. There was a recent review that I think it was a Cochrane study that said that, okay, now we really should be doing PSA on everybody again. And it's,
Wow.
I'm going to wait for the dust to settle on that. But there's a time and a place, but I think people are comfortable with proteins because they've heard of them. But the conversation needs to pivot, and they need to be aware of molecular tests like ours, and then hopefully have some supported decision making that the clinicians can support and say, hey, look, there is something better, and this is what I suggest, and here's why I suggest it.
Yep, definitely. Love it. We work with a population here. The city that I'm in is the healthiest city you've ever seen. It's the best. Everyone is fit. Everyone's
Nice.
training. Everyone's eating well. Vancouver is a different place.
That's wonderful.
People are scared of pancreatic cancer and lung cancer for non-smokers and genetic cancers. And, people are scared. In my family specifically, there are genetic cancers. In my wife's family, there's asbestos-related cancers. It's a scary place to be when you feel like you're doing everything right.
Yeah.
How does your test perform for some of the most dangerous, kind of difficult to detect cancers, difficult to find early, I should say? Tell me a little bit about it.
Great question. So you mentioned pancreas specifically, so I'll talk about that one just in general and focus on that one. We have a manuscript that was recently submitted, and it should be published. It'll probably be available. So if you look up Bernert, Bernert, and pancreas, probably in the next month or 2, you'll be able to find the article. But a lot of our collaborators, we work with a surgeon and his team at the Baylor College of Medicine and did a pancreatic cancer study. And for stages 1 and 2, and some would argue that stage 2 is even a little bit too late for pancreatic cancer. It's such an aggressive cancer. We have about 61% sensitivity for stage 1 and stage 2 pancreatic cancer. So
Wow.
we're going to catch most of them. And again, today, currently, it's 0%.
Right.
Which is one of the reasons the outcomes are just so dismal, is that people very rarely present with symptoms at stage 1 and stage 2. They present with symptoms when it's more advanced. And then, of course, the outcome is much more challenging. It's more costly. It's much more painful. It's just so much more, big surgeries it's just very difficult. If we look at, and then if we back up, okay, so that's pancreas, 61% roughly. So for aggressive cancers like liver, lung, pancreas, esophagus, cancers like that are very bad 5-year survival. So the bad actors that we're familiar with, not papillary thyroid cancer, which has a maybe 99% 5-year survival, but the ones that are really taking lives. We have for stage 1 and stage 2 sensitivity, we're closer to 65%. So we're detecting lots and lots of those stage 1 and 2 cancers where there is no current screening method. So I think that can be reassuring. And, for folks that have familial, for example, BRCA, or, if they've got a BRCA or if it's a Lynch, there's a group of folks that they're at increased risk for things like brain cancer, pancreatic, breast, kidney, things like that. One thing I will say is that of all the options that are available on the market right now, ours is the only multi-cancer early detection blood test, or MCED test, that detects brain cancer. And we just finished a study, and we were able to detect low-grade gliomas, or low-grade glioma like oligodendroglioma. And we were also able to detect diffuse astrocytoma, glioblastoma multiforme. And the sensitivity there is close to 50%, which again, everyone else is at 0%.
That's right.
So, and your listeners, I mean, a lot of people don't know the ranking of cancers, even clinicians, but brain is the number 10 killer, at least in the U.S. So it's a big cancer, and if you go with a different MCED test, you might be missing a number 10 killer, and we've got, again, about 50% sensitivity for brain cancer.
Wow. Incredible.
Yeah.
That's the perfect review. I think that gets the point across really, really well. Same person. Okay. Same person. Now you've given that review, and they're pretty happy with that. At least they have something significantly better than 0. Not perfect, but significantly better. Is it, and it comes back negative. Is it 3 years later? Is it 5 years later? I know it depends on the which tissue is most vulnerable, but what do you think is a decent follow-up? Remember, as a screening test, like, should I be saying every 5 years? What do you think?
So we don't know yet.
Yeah, you haven't made the recommendation officially. Sure.
Exactly. And we would want an external independent to make the official recommendations, because any company is going to say, oh, yeah, you need to take
every
this
year.
thing exactly.
For sure.
And exactly, right? So that is open. Nobody really knows the answer to it. What our goal was to make it affordable enough that it could be done every year if people want to do it. So that's kind of a goal of ours. And if you look at the growth rate of some of these very aggressive cancers, you wouldn't necessarily want to go 3 years, 5 years between screening, because pancreas, for example, liver, they move quickly. And if you get your specimen collected today and the tumor is so small or doesn't even exist yet, if you wait 3 years and the cancer starts next month, next year, there's a good chance it's going to be advanced by the time it is detected with the next one. So there is some literature, but it's industry literature. One of our competitors put out a paper that said every year is ideal, and the arguments are reasonable, but I really think it needs to be an independent body that looks at the data and says what the recommendation is. So certainly not more than once a year, but somewhere between 1 and 3 years. And it's going to, at the end of the day, Dr. Duizer, I think what we're going to see is, if you're 40 to 48, it should be every 27 months. And I'm just making these numbers up.
You'll see that, yeah.
If you're 55 to 62, it's going to be every 12 months. So as that pretest probability goes up, then they're going to probably shrink the intervals. That's just speculation on my part, but again, I think it's most important.
Yeah, that makes total sense.
It's open. We have people that do it every year. We have some people, for example, we mentioned people at increased risk, and the firefighter community and first responders in general, but firefighters in particular, are at increased risk, and it's occupational exposure. It's well described. For example, they have a much higher relative risk of kidney cancer and skin cancer and brain cancer and bladder cancer. A lot of those folks are doing it every year. Some of them are doing it every other year as their budget allows. For example, they might do whole body imaging in even years and EPISEEK in odd numbered years, because they are an increased risk, as would people with this familial high risk things that we talked about.
Yeah, another good strategy. I like that strategy as well for now, until we see the official recommendation. So And another situation we get in that's along the same vein is, and I asked you this when we first met, is I see a lot of people who are trying to prevent the recurrence of cancer who have been given the all good. Like when do we say, okay, EPISEEK makes sense again for you?
Yeah, so what we have, again, the science isn't fully mature, but our recommendation is if you are 3 years free, then it's a great time to start looking for late stage, or late recurrence or persistence of disease, if you want to think of it that way, and for new cancers. When people are being treated actively, we have no data to say what is the significance, if any, of an abnormal method EPISEEK test. So we don't recommend it during treatment when people know they have a tumor, because if somebody could misinterpret the result, you're treating them with a therapy, their EPISEEK comes back negative, and they say, well, I'm done, I'm not taking any more. So we don't have that. But after 3 years, we think it's a great time to look for recurrence. And we also know that people that develop one kind of cancer are at higher risk for developing another kind of cancer. So it's a great time to start screening with a test like EPISEEK.
Definitely. Okay. Thank you for that. I would like to take advantage of something just personally, and that is that you're the first pathologist I spoke about on the show, but actually, I think in real life too. And I've had questions for years. Not necessarily. I know one other person, but haven't talked to them professionally. And I'm wondering about your opinion, your experience, your knowledge around circulating tumor cell assessments, the CTC test. Can you tell me what you know about that and whether you think there's any value in that test?
Yeah, I think that for circulating tumor cells for screening, I'm not convinced that there is very good, compelling literature on that at this time. Okay. So CTCs have been used in people that have already been diagnosed with cancer. It's one other kind of liquid biopsy. So when we say the term liquid biopsy, generally we're just saying any kind of biofluid. It could be blood, saliva, urine, CSF, any of those fluids. We're looking for biomarkers in that fluid, and that is a liquid biopsy. I think circulating tumor cells have shown some value in folks that have already been diagnosed with cancer. It's kind of a way to pick up a little bit of those cancer cells that are intact and look at them and see, are there targets that are available? Is the surface antigens that we expect to be there, are they there? For screening, I haven't been able to find as much compelling literature. But again, admittedly, I'm biased. I have looked for it. I've spoken with a colleague whose opinion I value very much, and she works with a company that was offering CTCs for a short term in the US, and then they pulled out of the US and are offering it, I think, in Asia and in Europe. But it would be fair to ask them for some better scientific literature that supports their studies. I'm happy to give you mine, but I just haven't seen as much on that. But admittedly, again, I want to make it clear, I am a little biased and I haven't spent 12 hours digging deep on CTCs for screening. So in the screening space, I think it's light, but I'm happy to be proven wrong. But in other uses, I think there's some real opportunities with CTCs.
Excellent. Good to hear. Yeah, the reason I ask, I don't have any experience, minimal, with screening, maybe once or twice, but 2 cases in particular where we used it for assessing whether or not conventional care and integrative care and supportive care as a combo was helping keep them in a space where we thought was good, and had repeat tests where we thought that the number was at a place where your confidence would be quite high, and then took 6 months off, and for both of them things went sideways so fast. And it seemed like everything was going well, the numbers were showing good. They continued doing the same thing but without me, but in both situations there was significant progression. It was quite discouraging.
Yeah, and in that setting, I think there is good data to suggest that it has value in that setting. But in screening, I've not seen really good data on that yet.
Completely different. Yeah. Well, I that kind of summarizes my deep dive into how do I communicate this to patients. And I think that people will get a lot of value out of that. But I'd love to hear your experience so far. I mean, it's been 4 or 5 years. EPISEEK is taking off. You've already mentioned how it compares to other companies in the space. And I think that you're going to continue to do incredibly well and expand and hopefully get the cost down even further, even though it's, I think, well priced. What are some of the case studies that you can share where there has been just an incredible amount of value for your test? Can you give me 1 or 2 and walk me through what happened?
Yeah, so we can just go through the most recent case. And again, just to reiterate, if we do have an abnormal, one of the pathologists will call the clinician because, you might go a year without getting an abnormal methylation signal detected result. So it's always good to refresh, and we'll call and speak with the clinician. One that Dr. Ruth, my colleague, he's the medical director, a molecular pathologist, had that he was mentioning to me. We go over cases together. The most recent one was a patient who was otherwise healthy, lived in the Southeast Mid-Atlantic area, and had, abnormal methylation signal detected. And, the DH&P, nothing there, nothing obvious on the labs, and went to imaging and had a low-grade B-cell lymphoma diagnosed
Wow.
early. And I think we all know that, getting almost invariably early detection really changes this treatment and the outcome paradigm across cancer types. And this is one that was completely unsuspected. Patients feeling great, no signs, no symptoms, no class B, type B symptoms of, night sweats and that stuff, but was able to get diagnosed earlier and is currently in treatment. And, the idea is, wow, we had an impact. We changed the course by getting this patient diagnosed and detected earlier. And that's really exciting. Now I'll flip the script because as a clinician, we're a medically led company. So it's a bunch of MDs and PhDs. We don't have, big, heavy VC influence on our board calling the shots. So as a medical, colleague, I want to be honest too and tell you about a case that we missed that was very impactful. I haven't had a chance to show, and I encourage folks to visit our website. I'm sure it'll be available, but Precision Epigenomics or epi-seek.com.
Okay.
But visit the site, and I'll make this clear too, is that the test is very good at some cancers, for example, oral head and neck cancers, tongue, tonsil, larynx, for example, but it's not as good at some other cancer types. And there was a case, it was a physician's mother, and we had a normal, no cancer signal detected, and it turns out that she did have a breast cancer that we missed. And it's a very difficult conversation to have because the breast cancer, prostate cancer, those are on the lower side of the performance of the EPISEEK test. Fortunately, we have PSA and mammography to fill those gaps. But explaining to someone, hey, missing an early breast cancer is an expected finding for the EPISEEK test. And it's people's heads explode when they think about it. And it's always a physician or a lawyer's wife is usually when it's a missed breast cancer. But I just want to illustrate the point is that this is in addition to, not instead of, and that we are, I said that our stage 1 and stage 2 sensitivity is good. It, even for the aggressive cancers, it's maybe 60%. For all cancers, it's about 45%. So we're going to miss some cancers. But it's just something that we want people to understand. And I didn't want to just give myself a pat on the back and tell you about the great success.
Yeah.
I want your clinicians to understand there will be an instance, especially with papillary thyroid cancer, releases almost no ctDNA, so very, very difficult. Fortunately, not fatal very often. But things like breast, prostate, they can be challenging to detect. And so I just wanted to give a fair and balanced presentation.
Yeah. No, very fair.
Not just how awesome we are, but I want to make sure the clinicians ordering and counseling patients understand there will be missed cancers, even for those aggressive liver cancers, esophageal, 64, 65% sounds good. We're still going to miss a third. So
Yeah, right. Oh, completely.
yeah.
Completely. So, as a company, I think it doesn't pay off in the short term, but it'll pay off in the long term, to be honest like that, and
Oh, 100%.
to highlight those type of cases. So, yeah.
If nothing, we're honest. If anything, we're, it's always uncomfortable to have difficult conversations, but it's always better than not having the difficult conversation. And admittedly, that was a difficult conversation. It was early days for us. We were still trying to get ballast and get clinicians to start adopting the test. And, it was a difficult conversation, but like we said at the top, the patient is the purpose, and you just always tell the truth and things will work out. So,
Well, that really comes across from you. Is the science evolving here? Like, is the test changing? Is the test improving?
yeah, so that's a great question. We continue to do some R&D bench work. We have PhD clinical scientists in the laboratory doing analysis regularly. In fact, we knew that we did well with glioblastoma or brain cancers, for example, but we wanted to find out, and improve the confidence in the results. So initially we had an abstract presented at the Association for Molecular Pathology. They just had 7 gliomas, 7 high-grade gliomas, and we detected 3 out of those, which was, again, groundbreaking because no one had ever been able to do that before.
From 0 to 3, totally.
Yeah, exactly. But we said, look, 7's not a very big sample size. Let's prove this. So we recently completed another study that gets that sample size up to the mid-20s. And again, actually the performance increased. And we're doing things in the laboratory. The interesting about laboratory developed tests is you can't tinker with it too much while you're actually offering it clinically. So we have to keep the technology locked on what we're offering. But in the research background, we're saying, well, what if we do this? What if we do this for the preamp instead of that? And if we can show a bridging study that shows that that technique actually improves performance or makes it faster, then we can make those changes. But yeah, those kinds of things are always happening. And the more we do, the more we learn. So even the clinical cases that we're doing, we're working with a firefighter group that actually is doing essentially synchronous whole body MRIs. So they're doing the EPISEEK assay and they're doing the whole body MRIs within about 3 months. So for our purposes, that's synchronous. And we're going to look and say, okay, we know what our false positives and true positives and false negatives and so forth were before. Now we have this comparative. So we're always asking questions and making sure that what we're doing is sound and that we're not ending up with too many false positives or false negatives. So that's really important. And then the classifier itself, the probe set is more or less, we're using a certain defined probe set, but we're always looking at different probes. What if we added this? What if we added that? Is that can improve it for this type of cancer type? So that's always ongoing in the background. But rest assured, none of that gets rolled out unless we've got a strict validation study that bridges it effectively.
No, totally. And how do you see the evolution occurring here? Like, when do you see we get to a spot where every town has the test and the test is very low cost? And like, what do you think it will take to get there? And is there technology helping you get there quickly? Like, how do you think this next kind of period, because every other industry is moving insanely fast. And I'm sure you're kind of feeling it in your world. I just don't know the extent that you're feeling it. Can you walk me through a bit of that?
It is such an exciting time to be in medicine, and it's accelerating so much. So you're spot on in every area. It's just growing. My concept of what is end state for cancer screening globally, and I want to emphasize a regional solution that only people in Scottsdale, Arizona or Vancouver can afford is not a solution. In Kenya, for example, cervical cancer is still the number 1 cancer killer. Right. That comes out at the same time the UK celebrated, hey, we haven't had a cancer death from cervical cancer in the UK, in years. So that the disparity thing is hugely important to me to make sure we get there. That said, I think ultimately it's going to be true multi-omics approach eventually. So I think that there's going to be continued importance of the clinician in conversations and behaviors, lifestyle changes that decrease the incidence. We know roughly 40% of cancers are lifestyle related, whether it's smoking, alcohol, sugar, obesity, things like that, infectious disease. So I think it's going to be an end state where there's going to be, in 7 years, hopefully, there's going to be, you go in and you get your annual physical, you're going to get some blood tests done like we always do. And one of those blood tests is going to be a multi-cancer early detection blood test. It may or may not be ours. I'm not that presumptuous. But it's going to be probably circulating tumor DNA, at least for the next 7 years, because it's affordable and scalable. There are more expensive options, but they don't make sense for screening. And then I think there's going to be a role for imaging too. So we know that MRI, CT scans used to be very, very expensive. The cost of those is coming down even farther. So I think following up with imaging is important. I've used the analogy that, if you look at a coffee mug in one angle, it looks like a cup, and that could be like a laboratory medicine, a liquid biopsy. But if you look at it from another angle with imaging, you might say, oh, there's actually a handle. It's a mug, not just a cup. So I think multi-omic approach is going to be really, really important. But all of these things have to be, as unfortunate it is, there's a reality on costs. We can't continue to spend and spend and spend in healthcare. And we have to have something that's accessible and affordable. and having a locally run assay in each community on a PCR platform. And I think, there are a lot of PCR platforms all over the world from a certain, COVID bug that was around. So PCR platforms are ubiquitous. They're cheap to run. The specimens can be collected locally and maybe shipped to 2 hours to the nearest PCR instrument, whether it's in Papua New Guinea or Kenya or Winslow, Arizona, or, somewhere remote in Canada where they have even a small laboratory. Keep the costs low and make it accessible to everyone, not just people that can afford a $1,000 test.
Definitely. Well, that is a very positive outlook. I'm so excited for that. 7 years, I've written that down twice. I know that you just said it in passing, but I want to see that happen.
Yeah, I believe it. I really do. And I think if we get ourselves together, the House of Medicine says, this is important. This is what we are going to say is successful based on sensitivity and specificity for stage 1 and stage 2. And this is there could be even an efficient frontier on how much to spend. It's got to be less than this. I really think we can get it done if we all pull together.
Oh, that's excellent to hear. Now, where can clinicians find out more about your company? How can they get signed up for EPISEEK and learn more?
Yeah, so the easiest thing is probably to just search for Precision Epigenomics and go to our website. There's a contact form there. If you're able to share my contact information with the team somehow, maybe in an email, you can post it. It's a little bit lengthy, my email, but just go to the website, poke around, look at the FAQs. We tend to put our recent publications up there. So the brain one should be up there pretty soon. The pancreatic one is already in review and should be up shortly. But poke around and then just reach out. My cell phone number is in my signature line because we talked about it earlier. Communicating with the pathologist, even if it's not the medical director, is essential. Especially for tests like this, there is nuance. It's not just a yes or no. So that's the easiest thing is go to precision-epigenomics.com and poke around and then just reach out. And I'm happy to speak with anyone.
Excellent. Well, thanks so much for your time, Dr. Bernert. I think you guys are poised to change the world here. Screening is so incredibly important. And I look forward to being able to use your test and support my community with it.
Awesome. Thanks, Dr. Duizer.
Thanks again. Talk soon. Bye.
Very good. Bye now.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Duizer and at Get VitaminLab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.